Thanks, STEM India, for giving me this opportunity to talk about discharge medications and improving compliance. All of us know that despite the tremendous advantages in the reperfusion, the methodologies, and the therapeutics in managing STEMI care, they still have quite a lot of recurrence and mortality in acute coronary syndrome, especially STEMI. If you look at some of the data which has come, a few years ago, these were the main registries, ACS registries from India. The CREATE came first with the 20,000 patients, and the Kerala ACS came later, 25,000 patients. And we have multiple other smaller registries. And you could see that our in-hospital mortality and even the 30-day mortality were higher than when you compare ourselves to the GRACE or the ACTION or the EuroHeart registry. And that possibly led Rajiv and Dennis Xavier to write an article saying that possibly in India, we have a lower quality of care. Not really necessarily so, because that is the time when we have poorer reperfusion, and centers which was offering reperfusion, especially the catheter-based reperfusion, were lesser. And of course, I do agree that in India, our systems of care in STEMI is still wanting. And we have an excellent systems of care when it comes to a road traffic accident. But when it comes to a heart attack or a STEMI, we don't have a proper system. And maybe the STEMI systems of care, if you look at the very many metrics of it, we were giving too much focus. Possibly we were giving on the door-to-balloon time or the door-to-needle time, even though the guideline-directed medical treatment also are absolutely important, especially in counseling of the patient pre-discharge through a multidisciplinary team, talking to them about the importance of adherence so that will prevent the recurrent hospitalization and the long-term MACE. So these are also important apart from the changing over to the radial route and the earlier door-to-balloon and then door-to-reperfusion. This just shows. You can just see the comparison between this is guideline-directed medical treatment, then guideline-directed medical treatment, and an earlier door-to-balloon time, and this is shifting to the transradial route. So all these things, it's not just the early reperfusion alone which matters, but also, you look at that. When you have each metric is added, you can see that the chances of MACE reduction, repeat hospitalization, repeat visit are much, much lesser. So a proper discharge medications, a proper advice is absolutely important. Now, this is, you may call it now, we just discussed about the number of STEMI care metrics, and each one added gives you a phenomenal reduction in the post-discharge events. This is also important. One of the subset analysis of the earlier study that I have just showed you showed that if you take instead of the 3-step, you take a post-op protocol, then you may have. All of us agree that the woman patient with STEMI has a higher mortality. We can possibly reduce it or make it much better if we follow these same rules. They have a checklist of the admission discharge checklist and early reperfusion and switching over to radial. So all these are important to reduce the post-discharge burden of this patient. This is absolutely important for us, our country, that where the cardiovascular disease is still the #1 killer. And we have a tremendous amount of gaps, as I showed in the earlier data of very many Indian registries showing I told you about the lack of reperfusion in those days, but now we have tremendously improved in our reperfusion area. But still, the gaps on the guideline-directed medical treatment still persist. This is one of the Chinese data, which also showed that. Now, apart from the fact that the mortality is reduced substantially by using a early guideline-directed medical treatment, even hospital major bleeding risk are supposed to be much lesser and lesser in this huge database from China. If you look at the our Indian data, as I said, the CREATE came first. And look at that. We had almost a 6.7 mortality rate, and the in-hospital mortality in the Kerala ACS, which still continue as the largest Indian registry of ACS. And now look at that. We have again a high mortality, and a STEMI mortality in Kerala ACS was 8.4%. Primarily because of the fact that we have lesser reperfusion. But if you look at the distribution of the hospital death rate, you could see that there are very many centers where the death rates were much lesser, and there were centers where the death rates were huge. There was a very wide variability in the process of care. That included the reperfusion and the other guideline-directed medical treatment. So if now the essential drugs like a dual antiplatelet drugs, beta blocker, in hospital heparin, and high-intensity statin and RAS blockers, see, only some 50% received these drugs during the hospital and even at the time of discharge. Even there was a disparity between the in-hospital treatment and the medications advocated at discharge, meaning that we have to be doing a lot of improvement in planning the discharge, in having a multidisciplinary team, and maybe as Kim Eagle, who is a guru on the ACS care, told after he wrote an editorial in the European Heart Journal after the Kerala ACS registry, telling us that, see, apart from collecting the data, what we have to do is improve the quality of this care of this patient. I was showing you some of the earlier data. What about the newer contemporary data? This is the NIC registry data presented in 2021, giving us the data on 2020. Here again, look at that. We have a lot to improve when it comes to the guideline-directed medical treatment in post-STEMI and post-ACS care. So we have to be doing something to improve the discharge care, and insisting on having every guideline-directed treatment for preventing in secondary prevention on board at the time of discharge, apart from the advices on diet, physical activity, and a proper rehabilitation. Now, we started something a little early this was prior to the CREATE days, when we tried to improve the process of care in the acute coronary syndrome, and we involved about 40 physicians in and around in our local area, and gave them the guideline-directed medical treatment, called up the ICU nurses, called up the ward nurses, and talked to them and taught them about the electrocardiographic features, the in-hospital management, how it might be done, and also involved in the nurses was very enthusiastic, much more enthusiastic than the doctors. And we told them about how we can possibly at the time of discharge, they also can be done. They be there and tell the patients about the importance of patient adherence. And look at that. See, if you look at we divided them into the pre-intervention and post-intervention, about 600 patients, and we could improve the antiplatelet drug prescription, the beta blocker levels of percentage of patients on beta blocker, ACE inhibitor, ARB, and of course, the lipid. We were very good in our DAPT, but we were not so good in our beta blocker, RAS blockers, and statin. And even a smaller effort from our part can improve that. Of course, this was the largest randomized controlled trial in cardiovascular science ever done in India. The idea being, we have seen from the Kerala ACS registry, we have seen where we lack, why possibly the process of care and the increased mortality was there, basically because of the wide variability of the care that includes the reperfusion and also the usage of guideline-directed medical treatment. So basically, we wanted to evaluate a locally adapted quality improvement toolkit. No magic formula. This was just an admission discharge checklist, dietary advices, rehabilitation advices, and in case somebody develops a sudden cardiac arrest, what has to be done. And of course, most importantly, there is also an audit feedback report, which we gave to all the 63 hospitals. 21,334 patients we recruited, and 63 hospitals. So we gave each of these hospitals an audit feedback report every month, which made them realize that how they are managing their in-hospital treatment, their discharge at the time of discharge, and how they are comparing themselves to the other 62 peers, which made them possibly made them better. And look at that. Look at and this involved every group, the hospital, government hospital, non-profit, private. So the entire lot of, and you could see that in the initial, and this was a step wedge design where a group hospital, into 5 clusters. The 63 hospitals were divided into 5 clusters, and at the end of every 2 months, each cluster will go into the intervention arm, which include the toolkit that I just mentioned. You could see that in the initial period, you could see the definite difference between the intervention and the non-intervention group. But over the time, naturally, there could be contamination. There could be, by the time the care also, Kerala is a place where possibly right now it has more than 120 cath labs, and over the time, the process of care also betters. And look at that. We could improve look at the discharge medications list. It's a tremendous, if you compare the discharge medication list of ACS Cook, which is done almost 8-9 years after the initial Kerala ACS registry, you could see that we could improve the process of care, the discharge medications. And I will not say that is the reason why we could decrease the medicine. I told you about the 8.2% STEMI death rate in Kerala ACS. And look at the STEMI death rate, in hospital death rate in the intervention now, 2.8%. So over the years, the process of care became better, but also these smaller things matters to improve the adherence, improve the prescription pattern of the GDMT, and this can be definitely. Now, the implementation and acceptability of a quality improvement program, now, of course, which is basically supported by the management, physician, and all your nurses, pharmacists, everyone. This can be eminently done. The not so impressive mortality reduction in ACS Cook. There was no tremendous reduction in the mortality. It was a non-significant 13% reduction in the mortality. And it was a short-term study also. It was a month thing. So, but the most important thing is, if the cardiologist and the team and the multidisciplinary team are bent on giving the patients a counseling and every GDMT on board, which protects the heart against another episode, this can be done. Possibly what we have a little bit of data from the ELLIPS study, which also shows that I was mentioning about the importance of all the medication, apart from the psychological support, the socio-economic support, the other comorbidity prevention support. So the discharge time is one of the most important time. And if we spend a little more time and communicate with them, we can very well possibly improve the adherence and prevent the recurrence of it. Maybe, see, many of the time now, the immediately after the discharge, we keep the first post-discharge follow-up maybe about 4 weeks or 6 weeks. There was some data which also tell us that a delayed outpatient follow-up is not the one which best suited for us. Maybe we should be calling, especially the sicker lot with very many comorbidities, to have a 2 weeks follow-up, and so that we can titrate the medication, up titrate or modify the medications. That is another point which possibly should be keep in mind. So what is happening now? Now, after the quality improvement program, we have the ACCS. This is not a confined to India. This is a worldwide program. We have one center from Palakkad. Dr. Jagopal is heading that GATI program. This is the Global Heart Attack Treatment Initiative, the GATI initiative, and where again, basically by a smaller admission discharge checklist, communications, and spending more time with a multidisciplinary team, talking about the diet, exercise, other the adherence to the medication, the GDMT, the improvement. Look at the improvement. This is only an initial analysis which is presented in the last ACC, about 4,000 patient data. That also can have shown that very well we can improve the not only the dose to balloon time or the node to needle time, but also the improved prescription pattern of the guideline directed medical treatment. And look at it's all flimsy reason why we are not prescribing some of these drugs. I do agree. I'm not negating the fact that they cause some bleeding, but look at the percentage. It's comparatively lower, and all these are possibly, this can be circumvented if we spend a little more time with them, educate them, and tell them about this importance of these life-saving medications. So, ladies and gentlemen, to sum up, mortality from ST elevation asthma is definitely decreasing, but our systems of care, STEMI, definitely needs improvement, whether it comes to reperfusion or adherent to the guideline directed medical treatment. It's absolutely important that we should have an early reperfusion, whether it is a catheter-based primary PCI to begin with, or a pharmaco-invasive type of reperfusion, which sometimes is suitable to very many places in India. That's absolutely important. But equally important is improving the guideline-directed medical treatment at the time of discharge and in the immediate follow-up, and the smaller usage of quality improvement program with a locally adaptable, locally developed toolkits. As I said, an admission discharge checklist, dietary advisors on physical exercise, if possible, audit feedbacks also, which make them think that how our hospital fares. Also, planning an earlier post-discharge visit will help. Thank you for your kind attention.